Hi everyone, welcome to Lecture 20, where we're going to talk about Angelman syndrome and Prader-Willi. Again, make sure that you take a good look at the websites for both of this and make sure that you use them. You can also use them in your discussion posts for this week. But again, the main information that I want you guys to get out of these that might be on a quiz or an exam is going to be within these lectures. So don't feel like, again, like I mentioned in the last lecture, don't feel like you have to go through all of the websites and understand little thing that's talked about. I also think what's really nice is as you're looking at these various websites, and also you've looked at Autism Speaks and the National Down Syndrome Society, kind of compare and contrast them. And which ones do you think are doing a good job for family support and advocacy and explaining support planning and keep up to date on research and educating people? I think it's nice when you look at multiple websites for various disorders for you guys to kind of be able to compare and contrast what people are doing well or how things can be improved. And especially, again, thinking about that in a systems change perspective as far as educating the community and also members of that population. So when we're talking about Angelman syndrome, this is a neurogenetic disorder, and it has to do with a maternal contribution of chromosome 15. Again, the prevalence is about 1 in 15,000, and some core things that we see with Angelman are developmental delays overall, including various levels of intellectual disability, lack of speech, seizures, which we'll talk a lot about. That's really important to understand with Angelman syndrome, in addition to gross motor difficulties. So when we're looking at consistent developmental concerns for Angelman syndrome, there are no obvious difficulties at birth, but there are developmental delays are evident around 6 to 12 months. And this first is seen as unsteady limb movements or kind of walking, kind of jerky movements, and also an increase in smiling. Some behavior uniquenesses of Angelman syndrome, which makes them, again, really special, are frequent laughter and smiling and this apparent really happy overall demeanor and being really easily excitable, and also this uplifting of their arms, kind of like this, which also can look like hand flapping or waving. Speech impairment, sometimes there's little to no words, as well as difficulties in nonverbal communication, again, facial gestures and using your hands to speak, and also receptive communication seems to be higher than verbal and expressive language. So again, receptive language is our ability to understand language, and expressive language is like what I'm doing right now, I'm speaking. So when we look at some more frequent developmental concerns for individuals with Angelman syndrome, we see a delayed disproportionate growth in their head circumference by 2 years of age, and then also the seizures, which are really, really concerning for individuals with Angelman syndrome. The onset is usually after 3 years of age, and the severity also decreases with age. And when we look at their EEG patterns, they're usually abnormal with a characteristic pattern that doesn't correlate to typical clinical seizure activities, and specifically we see difference in their delta waves. And delta waves are those high amplitude waves, and again, this is similar to other chromosomal disorders that also have abnormal EEGs and also have seizure difficulties. So this, by looking at their EEG patterns, it can make it it can be helpful in diagnosing Angelman syndrome, specifically when we look at their delta waves. So some other characteristics that we see with individuals with Angelman syndrome. One is protruding tongue, a lot of stuff orally with the mouth, and also tongue thrusting. Difficulties with feeding and frequent drooling. Their mouth sometimes tends to be wider, and also their teeth are more widely spaced. We also see hypopigmented, so less pigmented skin in cases of deletion. What is the cause? I mentioned that uplifted flexed arm position during ambulation or walking and movement, and also this fascination with water and crinkly items, and also increased sensitivity to heat. And looking specifically at some of the sensory concerns, again, those are some similarities that we also see in an autism spectrum disorder, but Angelman syndrome is separate from an autism spectrum disorder diagnosis. So let's look specifically at the seizure activity for individuals with Angelman syndrome. So again, we see seizure activity in about 80% of individuals with Angelman syndrome. And again, like I mentioned, the average onset is around 3 years of age. The most common types, we've got atonic, which are those full drop seizures that last about 15 seconds. Clonic-tonic, those are the grand mal seizures, and these affect the entire brain and tend to be the most severe. And then these atypical absent seizures, and those are those petit mal seizures that you might not always realize someone has. They might just kind of look away or look really inattentive for a bit. So the atypical absent seizures can be harder to diagnose. And only 15% are able to control their seizure activity with various medications that are listed here, valproic acid, and so forth. And this isn't that different from the general population. If any of you personally have a seizure disorder or know someone that does, you know that it's difficult to control seizures. And even individuals have to go through a lot of times multiple seizure medications before they can find a seizure medication that works for them. And then very often what happens also is seizure medications just stop working. So it's difficult to control these seizures because the seizure medications, unfortunately, are not super great at actually controlling seizures. When we're looking at cognition, so intellectual abilities in individuals with Angelman syndrome, we do see global cognitive difficulties. We know individuals with Angelman syndrome perform better on tasks that are less abstract, so that are and involve minimal language. We know that motor aspects of cognitive tasks, so being able to manipulate things with your hands, for example, are difficult for individuals with Angelman syndrome. And we also see an increase in aggressive behaviors in situations with high cognitive demand, specifically when we're learning new skills. Aggression, again, varies greatly. This can include throwing objects, mouthing objects, hitting others, spitting, pitching, so on and so forth. Also, eloping, so trying to leave the room or activity. And we've also, you'll see sometimes like flopping on the floor, putting their head down with harder tasks, with those types of things. So in order to help with this, when you're working with individuals with Angelman syndrome, it's really important to use certain principles, specifically like ABA type principles, and also some things that just can help create some behavioral momentum or success. So specifically presenting easier tasks first. Again, that helps build confidence, using cause and effect. So if you complete this, then you get access to a desired activity or privilege. Making sure there's high amounts of verbal praise and also tangible, so things you can hold, stickers, small edibles, types of reinforcement. Making sure that you work in chunks of like less than 20 minutes. Visual schedules that accompany kind of verbal directions are really helpful. Having a work board that explains that that cause and effect piece. So if you do this, then you do this. And additionally, extra time to complete assignments, especially when you have lots of motor concerns. So when we're looking at sensory issues with individuals with Angelman syndrome, clinical studies of individuals with Angelman syndrome have demonstrated that sensory-seeking behaviors are very common. And it has to do with this UBE3A protein that it looks like there's some difficulties with that in individuals with Angelman syndrome. And we know that this protein really helps the brain be able to understand and kind of take in and moderate sensory experiences. And so some common sensory-seeking behaviors that are seen in individuals with Angelman syndrome are biting things, mouthing them, fascination with water or shiny objects, and also high interests in plastic types things. In order to help with this, a huge part of treatment planning for this is developing replacement behaviors. So whenever you kind of take something away from an individual, a behavior that's serving them, like engaging in maybe some inappropriate sensory experiences, you want to make sure you give them something that's more appropriate. So if they're biting or mouthing things that could be dangerous, giving them something that is appropriate to bite or mouth. Also making sure that you help with sensory aversion, like sensitivity to noise, smells, foods, and clothing. And this can be, through positive reinforcement strategies, and also kind of setting up the environment for success. So making sure that they have access to maybe some equipment like headphones, things like that, to help, especially like with sounds. It's important to note here that sometimes you'll see some information about sensory integration therapy. And this is not an evidence-based treatment, but an anecdotal report suggests that it may be helpful. And this is when you kind of, you'll hear about sensory diet, so incorporating certain sensory experiences in a structured way into an individual's kind of repertoire to help with sensory aversion. And again, anecdotal reports suggest that it may be helpful. But as your Sturmy and Didden book also talk about sensory integration therapy and some of those things that are similar to sensory treatments, it's currently not an evidence-based treatment. Doesn't mean that it might not be someday. But again, if it helps an individual personally and you're also engaging in other evidence-based treatments, again, through a positive behavior support or an applied behavioral analysis, kind of a mixed treatment package type of approach, then those things are always good too. And that's always the case when we're looking at treatments. If there, of course, there's an evidence-based treatment available, we should be using that. But also if things anecdotally are helpful for folks, then it's important. If it's working for them and it's not hurting them and we're doing, again, other evidence-based things, it's fine to do that as well. So to end our time with talking about Angelman syndrome, we're going to watch a video about some research that has shown that we might be close to a cure for Angelman syndrome.
The word that describes Finn to me most is magnetic, because he really draws people into him. I've never seen a kid with as many friends and acquaintances and just with as much energy around him as Finn has.
Finn loves people, being in new situations, exploring new things, being anywhere where stuff is going on, exploring what's over here, what's behind this.
He's a really social little guy. When his pediatrician said that we should probably go to see a pediatric neurologist because he wasn't sitting at 9 months, that for me was the first time that I ever considered that something might actually be wrong.
Do you want Play-Doh, Finn?
Approximately 1 in 15 to 20,000 births are affected by Angelman syndrome. Children with Angelman syndrome always have a smile on their face, and they always find humor in everything. Although this happy disposition sometimes masks this horrible disorder. They have a profound developmental delay, severe cognitive disabilities. Many of them have a motor coordination defect. About 80% have severe to moderate seizures that are sometimes very difficult to control.
I think when you get that Angelman syndrome diagnosis and you don't know, it's like, my kid will never talk, might not walk. There's just all these things that are really devastating. And yeah, might not walk was one of the big ones, so he's exceeded our expectations, I guess, which is stellar, but really well for Angelman syndrome is still really devastating. Yeah, hi.
At first, you're devastated a little bit for you because things evaporate. The image of who your child was disappears very quickly because you don't know what the life is going to be like for them. Will my child ever walk? Will my child ever learn to communicate? Will my child have seizures? Will my child die from a seizure? We lose kids every year because they have a seizure and they don't come out of it. Sophie has more challenges to overcome than other kids with Angelman syndrome. So, all kids are different. Kids with Angelman syndrome are different. Some of them walk right on time. Sophie still can't walk. She still can't stand up. Can we use our talker to say hello?
Good job. So
as much as I love my daughter's smiles and her giggles, I want to get rid of the seizures. I want her to be able to eat real food. I want to be able to talk to her. Do you want your drink? Yes. No, 2 drinks. I think, there's simplistic things that you want, but at the same time, they would be profoundly important for making her life better.
There are children out there that the clock is really ticking. We need to find a cure, and we need to find it fast. Angelman syndrome affects one single gene, and that makes it much easier to understand than, say, autism or schizophrenia or Alzheimer's disease, where many genes or environmental factors are involved.
Dr. Weaver has a mouse that mimics most of the symptoms of Angelman syndrome, so it's missing the same gene, UBE3A. The mice have muscle issues, they have seizures, it's very similar. And what Dr. Weaver found is you can compensate for the loss of the UBE3A gene. So he actually turned on a different gene, and when he boosted that gene in the mice, they recovered from all of their symptoms of AS.
We were able to genetically cure it in the mouse. So parents that have children that have Angelman syndrome should be very hopeful. There's a treatment out there, we just need to find it.
A cure for AS really is going to be a gateway to a cure for other neurological disorders, for things like Alzheimer's, for autism, for anything that affects learning and memory. So this is a chance where someone's investment can really pay off and they can see it. Every kid deserves an easier life. We really do hope people would be willing to help us on this journey and be part of the miracle.
I want a hug.
You want a hug?
So that video highlighted some of the pieces that I mentioned in the lecture about Angelman syndrome, and then also highlighted, that we're on, that with understanding, because it only deals with one gene specifically, and the UBE3A protein within that gene, it really helps us be able to understand it better, get closer to a cure. And anytime that we're able to have a genetic model of something like this, like the video mentioned, it helps us as we get closer to cures for other things, because we can apply that model for other disorders that have similarities to it. So the next thing we're going to talk about is Prader-Willi. And with this one, I'm going to open with a video. And with Prader-Willi specifically, I do want to point out, actually, take me off for a second, that I'm going to start with a video, and then we're going to go into the lecture. And Prader-Willi is something that, again, people are always a bit drawn to because it has a couple of people find really interesting pieces about it. And so I just want to caution you, and again, you have a website for you as reference, but if you just Google Prader-Willi, and this will make more sense as you learn more if you don't already know about Prader-Willi, that a lot of the information you get can kind of be a bit voyeuristic in nature, given some of its kind of core diagnostic features. So a simple Google search, again, you may get, again, some things that I just find a bit voyeuristic and not necessarily helpful for understanding the syndrome and understanding what it entails and the support planning for it. But just to get started, I'll show you guys this video.
Really makes kids sick because if they eat too much, they will overeat and then they gain weight and then they die.
Hi, I'm Elizabeth Ruth. I'm a senior research specialist at the Vanderbilt Kennedy Center, and I've worked with people with Prader-Willi syndrome for over 20 years. Prader-Willi syndrome is a genetic syndrome, and it's a small deletion on the 15th chromosome. And people who have it, about 1 in 15,000 live births, actually have a host of developmental and cognitive issues when they're born.
So in PWS people, the brain doesn't tell you you're full, so you're constantly hungry.
Depending on the severity of the hyperphagia, that they're experiencing, you have to lock cabinets, lock refrigerators. Meals have to be supervised. Portions have to be controlled. All these need to be an intricate part of their daily lives in order for them to survive. Without it, they suffer from obesity and all of the life-threatening illnesses that come with obesity.
She is food searching during the night, and that takes her sometimes outside. We've had episodes where she's gone to neighbors' houses, and I'm talking at midnight. There's been times where the school calls us to come get her every single day because of some type of behavioral issue, and most of it is triggered by food because she's just so anxious.
So it's an ongoing battle daily, all day, to get them to try to work to regulate when they eat. I know I can't control when he's hungry, but perhaps I can help him control when he eats. That's basically my job.
When I worked, I was surrounded with a lot of food that I really wanted to have, which I knew that I shouldn't have it. And I go ahead and want it because of the pleasure. It just makes me feel good when I choose it. I really want to have the life that I want with a dog and just have that. And I feel afraid that there's a chance that I could die, and I don't want that.
Whatever makes him happy is what I want for him. And if going to college and buying a truck and getting married and raising a family is what he wants, that's what I want. Those aren't incredible wants for a person. So why not? Why can't he have that?
So that video gave you guys some whoop, sorry guys, still had something else pulled up. Here we go. Gave you guys an initial look into Prader-Willi. And now that you see that a core diagnostic feature is this insatiable hunger, hopefully you guys understand some of my caution that I gave you guys on the front end about just Googling it. Because sometimes like talk shows and stuff will feature individuals with Prader-Willi, and again, it seems to be in a more voyeuristic way, where just kind of like, wow, this is amazing, rather than increasing awareness and understanding of the disorder. I'm not saying that globally, but in generally, again, I just caution you. So again, I think the Prader-Willi website is a good first place to start. I'm constantly trying to find new videos to show you guys, and whenever I'm looking for stuff about Prader-Willi specifically, whenever I teach this course, it's always hard. I have to navigate through a lot of just things, again, I find to be a little bit inappropriate. So just want to caution, you guys to that if you decide to Google it on your own. So when we're looking at Prader-Willi, like it's mentioned, it's a disorder on chromosome 15. There's 3 different ways which it's transmitted. The prevalence is about 1 to 12 to 15,000, and it's equally distributed across both sexes and race. Characterized early on and continuously by low muscle tone. Due to that, individuals with Prader-Willi cannot consume as many calories as the typical population. We also see hypogonadism, which is where their testes or ovaries produce little to no hormones. That hyperphagia, which is that abnormally increased appetite that we see. Cognitive impairments, these vary from some individuals with very mild intellectual disability or low average intelligence to more severe intellectual disability. And thinking about that and how with that not being able to control hunger piece, which we'll talk more about, how that can really complicate things in support planning, not understanding that, you know, as a product of having Prader-Willi, you're not able to consume as many calories as recommended for the day, you know, for a typical population, and then having this biological, it's not behavioral, insatiable hunger, you know, and then having a cognitive impairment, having to explain that on top of that can be really difficult. And again, so we'll see some behavioral difficulties, aggression, obsessive compulsive disorders that we'll talk about in this population, and then also morbid obesity. The mortality rate with Prader-Willi is higher than the general population, and that is due to complications due to obesity, and literally some people eating so much that their stomachs will expand and break, and then they will die. We know that people with Prader-Willi have a flaw in the hypothalamus part of their brain, which normally registers feeling of hunger and feeling satiated. And while the problem is it's not really fully understood, it's apparent that people with this flaw, so they never feel full. So imagine that you never feel full, you never feel satiated. And then in addition, so they have this continuous urge to eat that it's very difficult to learn to control. And again, thinking about how cognitive impairments on top of that can really make it more difficult. And like I mentioned, to compound the problem that they never feel full, people with Prader-Willi, again, like I mentioned, need less food than their peers without the syndrome because their bodies have less muscle and tend to burn fewer calories. And then we're going to talk a little bit about early development, which is very interesting because individuals with Prader-Willi obviously, or you'll see, actually usually have failure to thrive because due to this low muscle tone that impairs their sucking ability, and they require feeding techniques or tube feeding. So they can't get enough food really early on. And then again, we know that around school age, children with Prader-Willi develop an intense interest in food, and they can quickly gain excess weight if their calories are not restricted. So, like I mentioned here, when we're looking at Prader-Willi, there's two different stages. And the first one is we know that we'll see failure to thrive in this population. And so infants are usually hypotonic or have low muscle tone, which impacts their suck reflex. They'll also have a weak cry, and they're unable to breastfeed or be, or feed from a bottle, and they may require tube feeding. And then in the second stage, that's when we see this unregulated appetite, insatiable hunger between ages 2 and 8, which again are biological in nature. Their brain, the hypothalamus is impacted, so their brain's saying, I'm hungry, I'm hungry, I'm hungry all the time. And so they lack those normal hunger or cues that tell our body, like, I'm satiated, I'm good, I can stop eating. And then additionally, like I mentioned, to compound this, they have a lower metabolic rate. So they're not able to consume as many calories as that are typically recommended for the general population. So when we look at weight and behavior, we know that compulsive eating and obsession with food usually begins before age 6. Like I mentioned, the urge to eat is physiological and is overwhelming for this population. Again, due to low muscle mass and decreased activity, individuals with Prader-Willi are recommended to consume only about 1,000 to 1,200 calories a day, which is much less than what's typically recommended. Regular weigh-ins and periodic diet reviews are needed. And currently there's no medical intervention currently available to prevent restricted diet. And a lot of times what people think is, well, we know the hypothalamus is, is there anything we can do to stimulate the hypothalamus? And unfortunately, currently there's not any intervention on that front that seems to work for some reason for this population. So when we're looking at interventions and how we help this population, they're mostly behavioral in nature, which I'm going to talk about more now for you. So the goal that we need to the goal with treatment here is developing this idea of food security. And so we know that food insecurity contributes to overeating, poor nutrition, and obesity. And this isn't just individuals with Prader-Willi, but we see this with other individuals that have food security issues. And so food security is defined as the ready availability of nutritionally adequate and safe foods with an assured ability to acquire acceptable foods in socially acceptable ways. You'll also see sometimes kiddos in abuse situations that have issues with food security. They maybe didn't have food available to them readily when they were younger. But these principles, again, are applied to individuals with Prader-Willi. So we know the principles of food security, so when you're developing support planning, is there needs to be no doubt when meals will occur and what foods will be served. So usually lots of menu planning. There needs to be no hope of getting anything different what was planned, and no disappointment related to false expectations. So those are the core principles that guide food security and support planning for this population. So how do we do this? So how do we avoid food insecurity, and how do we achieve food security? So we make sure that we secure food accessibility across all settings by avoiding any spontaneity related to food. So, hey, let's go get ice cream, or, things that you might do, or parties, birthday parties, family gatherings. Those can be very stressful events. It's really important that there's no spontaneity. It's always really controlled, and there's always a plan. Absolute portion control down to even the condiments. Making sure that all food exposure is supervised, making sure that you have access to menus from restaurants in advance and decide what will be ordered ahead of time, posting the schedule for meal times and snacks and make sure all the menus and what will be served. And if necessary, because of raised expectations or anxiety, avoid places where social situations associated with excess food. Again, like birthday parties, those types of things. Family gatherings. It's also important to have controlled access to refrigerators, freezers, pantries, garbage cans, vending machines, and then money. And so just think about this as far as, again, through family stress, independence long-term into adulthood for individuals with Prader-Willi. There are specific group homes that specifically tailor to Prader-Willi because of the extra amount of support planning that's needed to help achieve food security. Because if not, again, we'll see complications related to obesity and death. So it's really, this has to be at the core of developing treatment planning and support planning. So when we're looking about other developmental concerns in addition to difficulties with food, we know motor skills. We know that motor milestones are usually delayed, and we also see a strength in visual motor skills. Oral motor and speech, we know that there are feeding difficulties. Also, poor oral motor skills, delayed speech, but speech can also be an area of strength. The children and also young adults and adults that were featured in that video, you saw most of them, again, had great expressive language. Cognition, IQs range from 40 to 105, so the average range, with an average score of about 70, so right around that mild level of intellectual disability. Additionally, we see difficulties with attention, short-term auditory memory, and abstract thinking, and strengths in long-term memory, reading, and receptive language. So again, in general, we usually do see some cognitive delays in most individuals falling at least in the mild range of intellectual disability, but there are some individuals that also do have average IQs. So when we're looking at just some other developmental concerns, growth, like I mentioned, there's a lot of times failure to thrive in infancy due to being, hypotonic. The growth hormone specifically is typically deficient. Looking at sexual concerns, because I mentioned some stuff about sex hormones, we know that testosterone and estrogen levels are typically low, usually a later onset of puberty, but contrary to a lot of misconceptions, individuals with Prader-Willi are not infertile. Other concerns are scoliosis, osteoporosis, type 2 diabetes, and also the skin picking and other obsessive compulsive type of behaviors. General health is usually good in individuals with Prader-Willi. If weight is controlled, life expectancy can be normal and the individual's health and functioning can be maximized. But again, there's this constant need for food restriction and behavior management, and this can be really, really stressful for family members. And again, you'll see that on the Prader-Willi website, there's lots of information about and support there. So pay attention to those pieces and also the attention it gives to family counseling. We know that adolescents and adults with Prader-Willi can function well in groups and in supported living programs. Again, if the necessary diet control and structured environments are provided. Employment in sheltered workshops and other highly structured and supervised settings, can be really successful. And residential and vocational providers, again, they'll really need to be fully informed regarding the management for Prader-Willi. And so I think it's, again, really important, again, to highlight with this, thinking about the implications and stress, the additional stress with the food management and developing food security that this can have on a population and their family. And again, long-term living options and independence. Because if you just think about food in general and what the social aspect of food with, like I mentioned, parties, graduation parties, birthday parties, family gatherings, going out to eat, that's something that, again, in general is typically not recommended for this population because it doesn't help with the difficulties with food security and food insecurity. So just think about the additional stress that presents for this population. Some behavioral difficulties, obsessive compulsive behaviors, picking at skin, hoarding, repetitive thoughts, and verbalizations. You can kind of think about how that might occur with this population, given the amount of control they have to have over their lives, dealing with food, how some other obsessive and compulsive behaviors can kind of arise. We know that we also see difficulties with changes in routine, tantrums, and sometimes physical aggression with this population. And looking at treatments, like I mentioned, there's currently not any treatment, unfortunately, but human growth hormone treatment was approved in 2000, and it does show a lot of promise for increasing height, decreasing body fat, increasing muscle mass, improving the weight distribution, and increasing their weight distribution among the, throughout the body, and increasing bone mineral density. And several studies also suggest that it may, though, increase behavioral difficulties. So there are some side effects. So human growth hormone treatment is promising, but again, the main course of treatments are behavioral in nature up till this point. So that's Prader-Willi. And so that is it for you guys. I hope that you've enjoyed this information. If you have any questions at all, please let me know. And we'll talk to you guys later. Thank you.